Hi, good evening. My name is Nirav Shah. I'm a pulmonary critical care physician at the University of Maryland. Welcome everyone to the ATS webinar today, care of the COVID-19 patient from home to the ICU. We're going to give it a minute or two to let a few more people log in, and then we'll get started momentarily. Thank you all for joining us tonight. Stay tuned. All right, it's 8:02. We have to be on time here, so we're going to go ahead and get started. We'll have people join us as they come along. So as I said, my name is Nirav Shah. I'm an associate professor at the University of Maryland, pulmonary critical care, Department of Medicine. I'm the associate chief for education and faculty development and the assistant dean for curriculum in the School of Medicine. I have the honor of hosting tonight's webinar, and the title of it is Care of the COVID-19 Patient from Home to the ICU. I'm going to let each of our panelists introduce themselves. We're lucky to have a very, very great crew here with a good lineup today. So, Steve, do you want to start by introducing yourself?
Sure. So I'm Steve Cassady. I'm one of the third-year pulmonary and critical care fellows at University of Maryland.
Excellent. Andy? Andy, you want to introduce yourself?
I'm Andrea Levine. I'm one of the pulmonary and critical care faculty members at the University of Maryland School of Medicine in the Division of Pulmonary and Critical Care.
Andy?
I'm Sandy Zaeh. I'm a third-year Pulm Critical Care Fellow at Johns Hopkins.
And Sapna.
Hi, I'm Sapna Kudchadkar. I'm an associate professor in the Department of Anesthesiology and Critical Care Medicine at Johns Hopkins.
Excellent. Thank you all. We're going to get started here with a quick poll question. So we're going to start a poll here and see if we can launch this poll. So tell us about yourself. Select one of the following. All right, let's see what we have here. So we have, you guys see that? Results, here we go. So we have 72% are MDs, DOs, or MBBSs. We have a few nurse practitioners or physician assistants and nurses, and then about 10% respiratory therapists and 16% others. So that gives us an idea of who we have with us in the audience tonight. That's great. And we're gonna kick it off with Dr. Stephen Cassady with our first case.
Okay. A patient that I wanted to highlight here actually dovetails well with what Dr. Levine will be talking about after me, and this is a patient that I was able to care for on her team in the MICU just this past week. So the patient is she's a 32-year-old woman, a mother of 3, who has essentially no past medical history beyond her prior pregnancies, and she presented to an outside hospital 31 weeks and 5 days pregnant. With a new oxygen requirement and respiratory distress, and she was found to be positive for SARS-CoV-2. So she was at the outside hospital for about a day and was requiring high-flow nasal cannula shortly after admission. Was transferred to our hospital so that she could be more closely followed by a maternal fetal medicine team. So she was transferred to us, and she was transferred to our MICU in with about 2 days on high flow, and with some attempts to, because she couldn't be prone because of her pregnancy, after positioning in the lateral decubitus position, it was becoming clear that she was failing high flow therapy and that she was ultimately intubated for worsening hypoxia. Her course was was further complicated by a recurrent severe metabolic acidosis, and she was continued on high-dose Lovenox because of such a high concern of hypercoagulability amidst her pregnancy. Like many of our COVID-19 patients, she progressed to a more severe ARDS picture. She had high oxygen requirements and high PEEP requirements up to 16, and required pretty heavy sedation with Versed, fentanyl, and propofol drips on and off to maintain ventilator synchrony. It was kind of, her course was made more difficult by the fact that because she was almost 32 weeks pregnant and had, because of the gravid uterus, she couldn't be safely prone positioned, which is one of the major salvage therapies in our arsenal for such hypoxemia. But one of the issues that repeatedly came up, especially for her, and I imagine continues to come up, is the enthusiasm about using, about the possibility of using experimental new drugs to treat her ARDS. And it was surprising, in terms of the amount of pressure that came from numerous sides to utilize these medications that, as of yet, are still being explored into their indications and their safety profiles. And this came kind of from all levels: patient families, allied health professionals, all the way up to actually other consultants who were seeing us, who were helping us manage. Ultimately, one conversation that between a consultant and Dr. Levine, the line came up where that was, well, you can't just do nothing, and it's tough because you understand both sides of it. Clearly, state-of-the-art ICU care isn't doing nothing, but you have to continue to basically be scientific and weigh the possibility of real harm versus the satisfaction of feeling like you've done something with an unproven therapy. Ultimately, the decision was made to explore compassionate use of remdesivir. Before she received the remdesivir, which is still pending, she actually was noted to have bleeding and had a spontaneous vaginal delivery overnight of a baby girl. The baby girl was brought to the NICU, had an APGAR score of 7 to 8, which I'm not an obstetrics expert, but reasonably good considering the circumstances. And the request for her for the remdesivir is still pending, but it seems as if that's likely to happen in the near future.
Great, thanks, Steve. I think that case brings up a lot of interesting questions and things that we can talk about. I'm going to launch our second poll now before we get into Dr. Levine's presentation. Poll number 2 is launching now. If given one choice, which therapy would you implement for your sickest COVID-19 patient? All right, I'm going to go ahead and close the poll. This is really fascinating. Let's share the results with everybody here. So about 34% said remdesivir, 3% hydroxychloroquine, 13% tocilizumab, 43% convalescent plasma, and then none of the above was 7%. I wonder, out of, just thinking out loud, how these numbers have changed over the last few weeks since we've been taking care of these patients. And I think that that's going to lead us into a nice conversation that Dr. Andy Levine is gonna kick off for us here on what's the buzz around various clinical trials for COVID-19.
Thank you guys so much for having me. I'm really glad Steve shared that story because it was a really nice clinical experience and a really sick but exciting patient to take care of. And I think Nirav's last question about how have your opinions about treatment changed over the last couple of weeks kind of brings me to why I was excited to present the presentation I'm going to give today. I think maybe my clinical desires and my ambition to treat these patients has changed over the last couple of weeks, and maybe yours will as well at the end of this talk. So let's see. So I do want to just give two disclosures. The first is that I was a co-investigator for the ACT trial, which we'll talk about. And the second is kind of dovetailing on what Steve just said, which is that I actually don't personally endorse any of the therapies for COVID-19. And so to disclose, I probably would have said none of the above were I participating in the poll. And really what I disclose and what I preach to Steve, who was my fellow last year, is that I really care about only one thing, which is high quality medical care, or in my case, high quality critical care. I did want to just have one slide before I started about an adaptive design trial, and this is probably well known to many of you guys listening, but just so we all understand the same language, there's a traditional trial design, which is how trials have been run for years and years and decades, which is you design the trial, you run the trial, and when the trial's completed, you analyze the trial. An adaptive design is much more in vogue these days, and I think is a much more novel way to run clinical trials. And so the way these work is that the trial is designed, the trial starts being conducted, and then there's an interim period where the data is reviewed, and then there's an adaptation that occurs. And that adaptation can be different things. So it can be that the drug is adapted or the randomization is adapted. So if, for example, you found that the drug seemed to be effective, you may change the randomization scheme such that more patients are randomized into the drug that seemed to be effective. And this is a really novel and elegant way, I think, to run clinical trials that allows us to get that answers a little bit faster and also answer more questions and study more drugs simultaneously. So the first trial I'm going to talk about, because it's been in the news all week and all weekend, is the ACT trial, and that's the Adaptive COVID-19 Treatment Trial. So this was an NIH and NIAID sponsored clinical trial. It was an adaptive design, as I just mentioned. The trial design was a 1-to-1 randomization with a placebo control, and it was double-blinded. It's a multi-center trial that I think ran at 75 sites around the globe. And ACT 1, or the first adaptation of ACT, was remdesivir, which was 200 milligrams on day 1, and then 100 milligrams thereafter for 10 days, and versus placebo. The primary outcome, which may come up in questions later, was time to recovery, and this was actually modified a couple of times during the different renditions of the protocol, but the final primary outcome that was used was time to recovery. And they defined recovery as saying that people are hospitalized but not requiring oxygen, or not hospitalized with just mild limitations on their activity, or not hospitalized with no limitations in their activity. So in the first rendition of ACT, or in the first adaptation of ACT, there were 1,063 patients that were enrolled. And the early preliminary results were actually released in a press release from this trial. So I'm going to share them with you here in case you haven't seen them already. And so what we found is that in patients who received placebo, there was an average of 15 days to recovery, compared to those who received remdesivir, it was about 11 days to recovery. And so that amounts to a 31% faster recovery time with a very significant p-value. The other piece of information that was released was that in the placebo, the mortality was 11.6% compared to 8% in remdesivir. While this wasn't statistically significant based on classical p-values, there is clearly a trend towards statistical significance. The first adaptation has actually stopped enrolling, and the trial is now going to adapt based on these findings. And so when the trial reopens, it will be perhaps remdesivir compared to another drug based on these findings. And that additional drug has not yet been disclosed based on the ACT protocol. So second trial I thought that was important to discuss is the hydroxychloroquine and azithromycin trial. So this is a Novartis sponsored study. There's 3 arms in this study. The first arm is hydroxychloroquine at 600 milligrams given on day 1, and then 200 milligrams 3 times a day thereafter. The second arm is hydroxychloroquine plus azithromycin. It's the same dosing of hydroxychloroquine, and the azithromycin dosing is sort of traditional Z-Pak dosing, which is 500 milligrams day 1, and then 250 milligrams, sorry, there's a typo there, on day 2 through 5. And then the third arm is a placebo. So a nicely designed trial with a placebo arm. It's a multi-center randomized double-blind placebo-controlled trial, as I said, and they're planning for an enrollment of 444 patients. The primary outcome that the study is intending to look at is the percent of participants who achieve clinical response. Wasn't exactly clear how they define clinical response yet, but that's their primary outcome. And then I just included some briefly of the enrollment and exclusion criteria, although there were some more than this, but it's looking primarily at adult patients who have signs and symptoms, for 7 days or less prior to their randomization into the trial. They're excluding patients who are actively in cytokine storm, any patients who have concurrent treatment with other SARS therapies, which was actually a exclusion criteria as well in the ACT trial. Creatinine clearance of less than 45, again, that was also part of the ACT trial. Anyone who has any EKG abnormalities, which I thought was interesting, either historical or present, which I assume will exclude many patients, and anyone who's pregnant or childbearing, which again was an exclusion criteria in the ACT trial, and perhaps speaks a little bit to Steve's question about what kind of therapy should we provide to pregnant patients, since almost always pregnant patients are excluded from clinical trials. At least according to clinicaltrials.gov, this study is not yet recruiting, so we'll have to stay tuned for the study results. The next trial I wanted to talk about, so I know tocilizumab is pretty hot in the news and is definitely being discussed daily in our institution, but actually there's data that already came out about sarilumab, so I thought I would share this trial with you guys instead. And so this is the evaluation of the efficacy and safety of sarilumab in hospitalized patients with COVID-19. This is a pharmaceutical-sponsored trial, again, an adaptive phase trial. It's randomized, it's double-blinded, it's placebo-controlled. There's 3 arms, which is the high-dose sarilumab at 400 milligrams, the low dose, and then the placebo. This was designed initially as a phase 2, phase 3 clinical trial. The inclusion criteria was that you had to test positive for COVID within 2 weeks of randomization. You had to have severe disease. They included patients who had a low ANC, who had elevated transaminitis, anyone who had been treated already with other immunomodulator kind of medications, including other IL-6 medications. They defined 2 outcomes. So the primary outcome for their phase 2 trial was a % change in the CRP, or the C-reactive protein, in 4 days. And then the phase 3 outcome was time to improvement. And they used an ordinal scale in patients to look at what was clinical improvement and to measure that time. So they released preliminary data from this as well in a press release, very similar to how the ACT trial data was released. So the phase 2 study completed enrollment of 457 patients. I think the initial plan was to enroll about 440 patients. So they completed enrollment and enrolled the target number of patients. They enrolled 3 different categories of patients, which was 28% patients were severe, and that meant they had an oxygen requirement. About 50% of patients were critical, which they defined as mechanical ventilation, high flow oxygen, or requiring ICU. And then 23% of patients who were enrolled were in multi-organ system dysfunction. The primary outcome, as I said, was the CRP, and they found that the drug did in fact rapidly lower the CRP at all severity levels of illness. And that was again at that 4.4-day marker. They did an exploratory analysis, and this was a pre-planned exploratory analysis of the clinical outcomes from the phase 2 study. And in this exploratory analysis, they decided to focus only on the severe and critical patients. So they excluded any analysis of the multi-organ system failure patients. And when they combined the severe and critical and compared that to placebo, there was actually no obvious clinical benefit of the drug. So while it met the CRP lowering, there was no clinical benefit. The data that they publish is here. So this is really dividing the patients into placebo versus low versus high dose drug. And so you can see on the first line is the % change from baseline of CRP, and there's a really remarkable change with both the low and the high dose of the drug. But then if you look at these exploratory endpoints in terms of clinical outcomes, if you look at placebo and compare it specifically to the low dose drug, there's really no significant difference between placebo and low dose drug. And then again, placebo versus the higher dose, you do see some significant improvement in the higher dose of the sarilumab. So after they did this analysis, like I said, it was pre-planned. They essentially have modified their trial going forward into the phase 3, and they've decided to discontinue the severe group because they found that of the severe versus critical, there was really no positive outcomes, no positive trends in the severe groups. They've discontinued that, and they've also discontinued the low dose drug group. I should indicate that they went back and reanalyzed the data, and they specifically now are analyzing the phase 3 data, which has been ongoing and being collected during this time period. And they actually do claim that the severe group did show a trend towards improvement, but nevertheless, because their data safety board said there was no trend, the study that is ongoing is just the 2 higher levels of illness at the higher dose of drug. So the next trial is a little bit complicated, but I think is a really eloquently designed clinical trial. So this trial is called Remap COVID, and it's actually a sub-platform of Remap CAP. This is a trial, so Remap CAP initially was really in Australia through the ANZIX studies and a little bit in Europe. And they built into their trial design Remap COVID, which meant that they could change their study design for pandemic states, which was a brilliant design in the Remap CAP. And this is a randomized, embedded, multi-center, multifactorial adaptive trial. And like I said, initially for community-acquired pneumonia, but now kind of remapped for COVID. And it's been, like I said, repurposed. And so I just tried to simplify it as best I could. And I'm sure I didn't include all of the information here. But essentially the way it works is there's simultaneous evaluations of what's called these different domains. And so what happens is a patient has to meet broad inclusion criteria for the study, and then they meet more specific inclusion criteria for each domain. So domain 1, for example, is steroids, and they're looking at fixed dependent steroids versus shock dependent steroids. The second domain is antibiotics, and there's 4 or 5 antibiotics within that domain. The third domain is immunoglobulins, which would be none or convalescent plasma. The fourth domain is antiviral medication, and there's a couple that I've listed there, including lopinavir, ritonavir, hydroxychloroquine, and combination therapy. And then the last is immunomodulation. And I think maybe I didn't include it, but so essentially what happens is the patient could be eligible to enroll in Remap COVID and then subsequently be eligible for the different domains. So they may be eligible, for example, for steroids, immunoglobulins, and antivirals, and then they would be randomized within those domains to one of the different options. And this really eloquently allows us to look at not only each of these individual domains, but the interaction between these domains. And as an adaptive trial, it allows the randomization to change based on findings that come out in interim analyses. So if you find, for example, that ceftriaxone does not result in benefit or causes harm, then this may drop out of the randomization or randomize patients significantly less frequently to ceftriaxone. I wanted to mention vaccines. So there's numerous vaccine trials that are ongoing. This is the Pfizer-sponsored vaccine trial. It's a randomized placebo-controlled trial, also pretty elegantly designed. It's meant to look at safety, tolerability, immunogenicity, and potential side effects. And it's 4 different vaccine candidates. There's 21 different arms to this study, and I had them all spelled out at first, and then I even found myself confused. So essentially the way it works is that there's low, medium, and high doses of vaccine. They're trialing 1 or 2 doses. They're looking at different age groups. And then there's 3 additional placebo arms. And again, it's looking at safety, tolerability, and the immunogenicity of the vaccines. Now, the primary outcomes, so there are 10 primary outcomes listed, which is kind of incredible. And they're mostly looking at local or systemic events like reactions, allergic reactions. And then they're looking at hematology and chemistry changes for the immunogenicity, for some immunogenicity markers. And then the secondary outcome is really focused on immunogenicity. And they're planning to enroll 8,600 patients. Again, according to clinicaltrials.gov, and I've included all the clinical trial numbers in the titles, they're not yet enrolling patients. So we can look forward to this vaccine trial. And then I think the last study I wanted to mention was this expanded access to convalescent plasma. This is a study that's being led by the Mayo Clinic. Mayo Clinic is serving as the central IRB on this study, and it's supported by the US government. What that means is unclear from the Mayo Clinic and the drug website, but nevertheless, that's what is said. And you can find out more information if you go to the website that I included here. So the study population is severe or life-threatening manifestations of COVID, and they define severe as people who are dyspneic, tachypnic, hypoxic, have a P to F ratio that would classify as mild ARDS, anyone who has infiltrates, and then life-threatening is respiratory failure, septic shock, and multi-organ system failure. At least according to yesterday, I think is the 4th. So yesterday, the program participation claims that they have over 2,000 sites, 4,600 physicians, 10,000 patients that are involved, and they've infused 5,000 plasmas. The objectives and endpoints are listed here. So the primary objective is really to provide access to COVID-19 convalescent plasma. And the endpoint they're examining is what is the availability of the convalescent plasma. The secondary endpoint is a safety endpoint, and so they're looking at SAEs, or severe or serious adverse events. And then the tertiary or exploratory endpoint is healthcare utilization, and they're looking at what's the length of stay in an acute care facility, how many days are patients staying in the intensive care unit, and how many patients are surviving to discharge. So those are the studies that I've decided to focus on, a little bit of everything, ranging from antivirals to convalescent plasma to influenza or to COVID vaccines. And there are dozens and dozens and dozens, and maybe even hundreds at this point, of clinical trials that are ongoing. Some are very small, single center, some are large, multi-center clinical trials. And really you could get lost in clinicaltrials.gov if you try just to search COVID-19. So I tried to highlight ones that are kind of in the media and in the news and using drugs that people are talking about. That's it.
Great, thank you so much, Dr. Levine. So I am going to just quickly check here to see if I can see any quick questions. A couple of translation questions or translating questions. There we go. Okay, so with that, let's go into the next poll question. And I will start that here, and let's launch this poll. Which of the following is the hardest part of managing your COVID-19 patient? Select one of the following: respiratory status, like poor lung compliance or severe hypoxia, ventilator dysynchrony, second one, multi-organ failure, third one, social isolation, fourth, thromboembolic disease, and fifth, peer pressure to institute therapies. More answers coming in here. All right, let's go ahead and close that poll and share the results. Looks like we have a pretty solid distribution here. So a third of the respondents said respiratory status, a third said multi-organ failure, about 16% said the social isolation, 7% the thromboembolic disease, and then 13% peer pressure to institute therapies. Interesting, very divided group here as to what the hardest part is in managing these patients. All right, so with that, we're gonna step into the next case presentation by Dr. Cassady and Zaeh from Hopkins. Go ahead, Sandy, you're up. Let me make sure you're unmuted here. And there you go.
So I'm going to present the case of patient Mr. A. And this was actually the first patient with COVID-19 at Hopkins. And I actually was able to see him today in our post-COVID televisit clinic, which was great to see how he's doing. So this is a 40-year-old gentleman who has no significant past medical history. And he developed fever, chills, cough, and shortness of breath starting in mid-March following a trip to visit his family in Fort Myers, Florida. And at baseline, Mr. A is a very fit individual. He runs marathons, he participates in Spartan races, and he's active on a basketball team. And so when he returned from this trip to visit his family, he presented to Sibley in DC in respiratory distress, and this was March 15th. And there was found to be COVID-19 positive. He was interestingly also found to be influenza A positive and rhinovirus positive on a viral swab. So he was in respiratory distress, he was intubated, and then he was transferred to Hopkins, to downtown Hopkins. And he had a prolonged ICU course. So he was in our ICU from the 16th of March through the 14th of April, so close to a month. And he was intubated from March 15th to April 9th. So it gives you a sense of a pretty long period of time. When he first came to Hopkins, his P to F ratio was about 120. It was lower in subsequent days. I think it was in like the 60s to 80s, days 2 and 3 of his hospitalization. He was requiring FiO2s of up to 80% with plateau pressures in the mid 20s, and PEEPs anywhere from 10 to 16. So he was managed with low tidal volume ventilation, deep sedation, neuromuscular blockade, and required proning 3 different times during his hospitalization. And he was initially treated with oseltamivir. As I mentioned, he had had flu, was also on broad spectrum antibiotics, which were transitioned to oxacillin as his first sputum culture at Hopkins grew MSSA as well. And then unfortunately had recurrent VAPS during his hospitalization, which is in part what made him, what made him intubated for so long. So sort of towards the end of March, he had Klebsiella and E. coli growing in his sputum, so that was treated. And then again, in early April, he had respiratory decline, worsening clinical status, again in the setting of having a more resistant Klebsiella in his sputum, so that was treated as well. He did not receive any additional therapies, meaning things like hydroxychloroquine, remdesivir, any of the additional therapies that we just spoke about. And then I think the other thing of note was that he was found to have a decreased ejection fraction. So presumably this gentleman had normal cardiac function to begin with, and was found to have an EF of 40%. So in the setting of being deeply sedated for neuromuscular blockade, and in the setting of his repeated VAPS, he received a significant amount of sedation, and that was in the form of IV fentanyl, IV Midaz. We also had started him on oral agents in an effort to conserve some of the IV therapies. And then he was receiving Precedex, Seroquel, Haldol at various times during his intubation course. He was quite delirious as he was starting his pressure support trials, and he actually self-extubated in early April. He ended up being re-intubated 2 hours later in the setting of tachypnea, paradoxical breathing, and thankfully was successfully extubated without issue 2 days later. And his delirium was actually a little bit better at that point. And what I wanted to highlight was, this is a very fit in shape guy to begin with, but obviously in the setting of this prolonged hospitalization had marked weakness by the end of his course. Our physical medicine and rehabilitation colleagues saw him on the 9th, the day he was extubated, and found that he had significantly impaired mobility and ability to perform his ADLs. He had physical deconditioning, and he had cognitive impairment as well. The following day after his extubation, he was seen by speech, and he was found to have poor coordination between respirations and swallowing, increased risk of aspiration, and of course made to remain MPO. To give you an idea, when he worked with PT that day, he was able to stand up 3 individual times with assistance, but was markedly tachypnic each of those 3 times. It's pretty remarkable that this guy had been intubated for close to a month and was still able to do that, but was very deconditioned, going from being a marathon runner to barely being able to stand on his own. And so his agitated delirium slowly improved. He was treated with olanzapine, and he was actually also put on a fentanyl patch, which was tapered over time, given he had had such high opioid necessities. And then he was transitioned to the floor, and he worked almost daily with physical therapy, occupational therapy, SLP, progressively improved in his status with all of these issues, and was able to be discharged a week later, so the 21st of April. And he went home alone to his apartment in DC. He was very nervous about infecting his family, and so he didn't want to be around his elderly parents. And so to give you an idea, he was 215 pounds, and as he says, 9% lean body weight when he first got to the hospital. And at the time of hospital discharge, he was 169 pounds. So he really lost a significant amount of weight. So when I saw him today in the post-COVID follow-up clinic, he was remarking about how far he's come even since his hospital discharge. He was able to do a run walk yesterday, which I was shocked by. I was like, that's more than I've done today. But he's continued to work with outpatient PT, and we screen all of these patients for depression, anxiety, PTSD, and he actually screened negative for each of those things. And he had a great quote that he said, which was, I feel like I'm preparing for a Spartan race again, and I look forward to the challenge. I just pray I get my lungs back, because he feels like his breathing is just not quite back to baseline. And so I thought that this case brought up a few interesting issues. One, obviously, as we've seen with other critical illness, that patients have significant impairments following long ICU stays. Even people who are very, very fit at baseline are going to have significant impairment. Second, that families and rehabilitations are nervous about taking on patients. I think this patient sort of had the best case scenario in that he was able to recover enough function to safely go home by himself, but in speaking to our hospitalist colleagues who are discharging a number of these patients, rehabs are often nervous about taking patients, and families are nervous unless they've tested negative repeatedly because they don't want to be infected. A few beds on the Hopkins hospitalist COVID floor unit have been dedicated to acute rehab for COVID positive patients. That's sort of one workaround that they've come up with. But certainly, all kinds of challenges for these patients that are sicker at baseline than this individual was. That's it.
Awesome. Thank you for sharing that case, Sandy. I think it's even more impressive that you took care of the patient, then you got to see him in clinic today and share that with us. So thank you very much. That's fantastic. Let me go here to our next polling question. We are going to launch this last polling question here. Which of the following long-term sequelae do you think would be most important to monitor? Neurocognitive recovery, pulmonary function, inflammatory biomarkers, post-ICU syndrome, or cardiac function? All right, we're approaching about 65% of people voting. We're at 70. All right, let's go ahead and close that and share the results here. So about 16% neurocog recovery, 49% pulmonary function, 2% inflammatory biomarkers, a quarter post-ICU syndrome, and 6% cardiac function. All right, very good. Thank you all for sharing what you think is most important to monitor. We are going to go ahead and hide those results here and move on to the presentation by Dr. Sapna Kudchadkar from Hopkins, who has a very unique perspective on this. We're glad that you could join us today. We just to give you guys a little bit of background. Sapna and I go back a little bit because our daughters were on the same basketball team for a little bit, so that was really nice and fun. And then I realized that Sapna's a celebrity on Twitter, and so I was able to follow her on Twitter as well, where she did highlight a lot of her experience in what she's going to share with us as well. So let me go ahead and make sure that she is unmuted here, and so she can go ahead and share her experience of COVID-19.
Thank you, Nirav, and hi everyone. Thank you. So I think this was the perfect segue to hear from Steve, Sandy, and Andy about the clinical trials and all of the exciting things that are happening, but also putting it in the perspective of ICU patients that you've all taken care of. My COVID-19 journey has been very diverse and actually culminated in a very special way today. So I can say that I have not only been a COVID-19 patient, but also have experienced it on the physician side of things as all of you, but also as a researcher, have been using social media extensively to promote information dissemination across both the adult and pediatric critical care communities. And finally, as a research subject. So when I say I culminated today, I actually donated 825 mLs of convalescent plasma this afternoon before signing on to the webinar. So it's been quite a journey. So if it's okay, Nirav, I'm just going to kind of start from the beginning and provide kind of just some general perspective and insights that I've gained over the last 6 weeks. So this journey really started 6 weeks ago, March 16th. I remember it vividly. And as you all know, March 11th is when the WHO, I believe that's the correct date, declared COVID-19 a global pandemic. And at the time, I remember, there was a lot of buzz, and obviously the hospital responses had really begun, but we had just started getting notifications of our travel being canceled and conferences starting to get canceled, and our usual academia life was significantly changed, but also hearing about potentially how we were going to have to respond to this in the hospital setting. At the time in Maryland, where I am, and where Sandy is, and well, actually where most people are, it was actually very early in the course, and there weren't that many cases that had been diagnosed, which may be a combination of not having sufficient testing at the time, et cetera. So March 16th was actually my first day in the PICU. I'm a pediatric intensivist and anesthesiologist at baseline, and I'll talk about kind of how that's evolved over COVID-19 times. So I came on service on March 16th, and really not much is different in the hospital at that time. If you guys can all take a step back and remember, you know, we were doing social distancing, you know, a lot of schools had closed and people were staying at home. But in terms of how we're running rounds, we generally were, you know, just standing in our large circles on rounds in the hallways, but just larger circles, much farther apart. Things we maybe weren't thinking about as aggressively were things like our ASCOM phones that we frequently like hand to somebody, for example, when we're, you know, in the middle of rounds and something urgent's going on. Some of those things that kind of, you know, we know hand washing is important, but kind of those in the moment things that we weren't thinking about deeply. And the reason I bring that up is because I actually did not get COVID-19 from a patient. I actually contracted it from a colleague. So at the time, we found out that there were 2 other staff members in the PICU that had come back positive that week. It was actually my fellow who I did a lot of procedures with. We intubated several patients during the course of the week, did multiple procedures together. That fellow only had a sore throat as symptoms. And so at the time, sore throat really wasn't coming up as one of the like key symptoms to be looking out for. By the end of the week, I was really tired. I was starting to have muscle aches, and you know, at the end of a long service week, you can all attest to the fact that muscle aches aren't that unusual. So I just figured I needed a massage, but there was nowhere to go get a massage, so there was that. But anyway, I started to have low-grade fevers the next day, and subsequently my fellow called me to say that they had come back positive. And so I went and got tested later that afternoon at Hopkins. Those of you who've seen the Johns Hopkins like iconic dome, I didn't realize that you could actually drive into the circle in front of the dome, and that's where they were doing the COVID testing under a white tent. So my test came back positive within 24 hours, and I was one of the first 200 cases in Maryland to come back positive. So it was an interesting emotional experience, because in a way I was slightly relieved, like maybe, okay, I seem to be okay right now. Maybe this is just going to be a mild thing, and maybe I won't have to worry as much moving forward. But at the same time, it was a little bit isolating because there weren't that many people to talk to who had the experience. And luckily, most of my healthcare colleagues had not contracted the disease. So I immediately went home to my bedroom. I'll remember it vividly. I came home at 9 p.m. that night. My husband had set up a industrial-sized trash can in the master bedroom with a mini Walmart microwave and a case of bottled water and a yoga mat. So those were my accoutrements in the bedroom. I went into that bedroom for the next 14 days and I didn't come out. I had a little tray outside of my room that they would bring me food, and I used disposable things, recyclable disposable stuff in the meantime, and did not have any face-to-face contact with my family members. I have an 11-year-old daughter and a 14-year-old son. The 14-year-old's not so into cuddling anymore, but the 11-year-old daughter still is. And so that was a really, really tough time. And at the beginning of isolation, actually, I was kind of like, oh man, and I'm sure all of you have had this thought, I'm going to be so productive during my downtime. I'm going to be sitting in this bedroom. I'm going to write so many papers and analyze all that data that I said I would. And literally nothing happened. For 7 days, at least, I could not even I couldn't concentrate on anything. The fatigue was immense. Like, it was intermittent fatigue that would come and go. I would feel great 1 second, and all of a sudden I would want to nap for the next several hours. So it started out with mild cough, fatigue, muscle aches. And then slowly but surely, I realized that my smell was gone. And that was also the same week that this whole anosmia thing was a big hot topic. Now we all are well aware that anosmia is a key symptom. At the time, it was just kind of case reports here and there. And I realized, because I was dumping diffuser oil in my diffuser, and I kept dumping it and I kept dumping it. I was like, gosh, why is this diffuser oil so cheap? And I realized in that moment that I could not smell anymore. By day 6 or 7, I started to notice that I was having a little bit more dyspnea with just kind of walking to the restroom. I didn't have a portable pulse ox or anything like that, so I don't know what my saturations were like, but every morning I felt the crackles. I felt when I took a deep breath, I could feel that if you got a chest x-ray, probably my lungs didn't look normal. But luckily, I was not having immense shortness of breath. I was able to recover at home. And the end of that isolation life story is that, and this comes full circle with what Sandy was talking about, and these long-term patients that are in the hospital for so long. After 7 days, I started to feel really, really down. I was, for those of you who know me, I'm a pretty upbeat, energetic person, and I felt like I was depressed, and it quickly hit me that I was lacking human touch. Like, I had not had the benefit of human touch for a very long time, and FaceTime and Zoom, and everyone's on Zoom calls all day long, and none of that could even come remotely close to the face-to-face contact, let alone the human touch that we're all so used to having and take for granted on a daily basis. So I got through that time. My daughter actually kept it together until day 13, and then she broke down on a Zoom call when we were reading a book together with screen sharing and said, "Mommy, I thought I could make it 14 days and I can't do this anymore." So day 14 was really glorious. If you go on Twitter, I have a hashtag Sapna's COVID diary. There's a video of me emerging from my bedroom to chariots of fire. So I said, okay, that was my husband and my brother's doing, so I don't judge. So after I came out of isolation, I felt very blessed. I was healthy. I didn't have severe disease, but I also kind of felt helpless because I hadn't been in the hospital when all of my other colleagues had been kind of coming and on the front lines and combating this first line. I was just watching stuff on social media and reading a lot of emails. Again, tons and tons of COVID emails, but didn't have the context. They asked me, since I'm an anesthesia trained provider, so they asked me if I'd be willing to go back into the adult ICUs since that was where the need was. Luckily, the one saving grace of this disease, but that story might be changing now, is that children aren't as significantly impacted by severe disease in COVID-19. However, in the last week, there have been some really concerning case reports of inflammatory syndromes that are consistent with a Kawasaki or a toxic shock-like syndrome in children who come back positive or maybe are negative on testing. So that story remains to be seen. That's a different webinar. I went into the adult ICUs excited, but at the same time very trepidatious. I was excited to care for adults, and it kind of came back very quickly. Obviously, I'm not as skilled as you guys are on the webinar, but I was able to use a lot of my pediatric ICU skills. And we do take care of adults, often 22 to 25-year-olds in the PICU. So learning geriatric medicine again was a little bit of a refresher course. What I learned quickly is these patients who are coming out of the ICUs, I started on a step-down unit, which was a really interesting perspective because I was seeing these patients who maybe were only in the ICU for 1 or 2 days. Some of them were there for weeks. Some of them were there on high flow nasal cannula and quickly came to the step-down unit. And what was fascinating to me is that even 1 or 2 days in the ICU on high flow nasal cannula, almost 75% of my patients were having acute delirium in the step-down units. And the challenges of not having family at the bedside to tell us what their baseline is made it very challenging. Bringing these teams together, my surgery resident would make sure every morning, because he knew my research is in mobility. I work very closely with Dale Needham at Johns Hopkins, and my goal was to get every patient out of bed and next to the window looking at the sun every morning. And my surgery resident, who was the junior intensivist, made sure that happened. And I would talk to the patients about how I had COVID too, and that how I was blessed. And although I couldn't understand what they were going through, that I knew a little bit of what they were going through and hopefully could connect with them in that way. And so that was really eye-opening. In the interest of time, I'll kind of move forward to kind of the biggest take homes that I've been processing emotionally over the last couple of days. Actually, I've had a few patients pass away or be in end of life situations, and I was having a really hard time with it. And a lot of people think, well, she sees children die in the pediatric intensive care unit, so this must not be as much of an impact. But in fact, it's had a significant impact on me. These are patients who've lived 70, 80 years on this earth, and then they don't have a family member at the bedside often when they die suddenly, if it was unexpected or we didn't have time to plan for a family member to have special permission to come to the bedside. And then I also realized what I was dealing with is a little bit of survivor's guilt. So, kind of what I was blessed to have this disease and come out of it, you know, pretty much unscathed, and be able to talk about it and donate plasma and do all of these things. But then there are patients who are not that lucky. And so that's been a challenge to tackle that specific emotion. But really, and now I've come back to the PICU briefly. I'm going back to the adult ICUs. I'm responding to airways and codes on the adult side. So I really kind of checked out the whole hospital at this point. And it's been a very broad experience, but I just want to emphasize and echo what Sandy talked about with that, you know, perfect case of, you know, the importance of rehab and survivorship. So luckily, many of these patients are surviving, even if they're severely critically ill. And at the beginning, the focus was so much on the survival. I think that some of the basics of ICU care often kind of went to the wayside. So we talk about the ABCDF bundle and ICU liberation. All of those concepts are still completely relevant. Maybe it's a little harder to sedate COVID-19 patients, for example, but getting the rehab teams to the bedside early, starting these rehab regimens, because these patients are very, very weak. And they're also having cognitive impairment that needs to be addressed early on so that we can have the best outcomes from them moving forward. So last but not least, donating plasma today. I found out a week ago that my antibodies were robust. I was a little nervous about that, but that's when I got the green light, and I'm hopeful that that plasma will hopefully help someone, and I'm waiting to see when the next cycle is that I can donate again. So I will stop there, and I want to make sure there's time for questions and comments. Thanks.
Thank you so much, Sapna, for sharing your story and all the work that you're doing on the front lines, and everybody on this webinar for all the hard work that you're doing. There were some questions here that maybe we can start with. You know, the first couple are for you, Sandy. It was, did you ever retest your patient, and was a trach ever considered given how long the patient was intubated for?
Yeah, so he ended up getting retested a number of times, and part of that was because the initial thought was that he was going to go to a rehab facility instead of going home. And so he eventually tested negative, but he had a number of positive tests. And I think a lot of the rehab facilities require you to have, it's 1 or 2 negative tests before they accept patients. And so in speaking to some of the hospitalists, they were saying it's actually a challenge sometimes with getting people out of the hospital because they're testing positive repeatedly. And then also that family members don't want to take people home that are positive because, you know, they worry about getting COVID themselves. And then second, yes, a trach was considered, and actually, so he was like the first, he was the first patient that we had. And so we were sort of figuring out how to do trachs safely is what I would say, and at what time period that should really be done. But the plan, if he was not successfully extubated that second time, like he was on the schedule to get a trach, so he was going to be trached, and then luckily he was able to be successfully extubated. But now we're sort of pushing the timeline back, and rather than traching people a little bit later, we're moving towards traching people when we would normally trach people. So at like 14 days.
Great, thanks, Sandy. Andy, I think this next question, I'm not sure you're going to be able to answer it, but it's when will a vaccine be available?
I don't know. That's a good question. I think we're probably months, if not a year away from that. I think that the vaccine has to be designed, and I think they have good candidates. They're obviously trialing them, but they have to go through phase 1, phase 2, phase 3 trials, and then do the analysis on the trials. So I think it's unclear, but I don't think it's going to be for at least many months.
Excellent. The next question here, Sapna, there are a couple of questions for you. I can kind of rapid fire them at you. Did you take any immunity boosting supplements during your isolation?
I'm so glad someone asked that, because I was thinking of what I left out during this course. So it's so funny. So I started sharing my my diagnosis on Twitter once I felt it was safe and probably that I wasn't going to die. So it was probably around day 8 to 9 that I shared, and the number of direct messages that I got from people across the world sending me their like ideal immunity boosting regimen was amazing. And so I made I I made a conscious decision not to take an immunity boosting regimen. I just thought we knew so little about this disease, and I was having mild enough symptoms. The only thing, I did read something about vitamin D at some point, and I do have low vitamin D levels, so I did take that. But otherwise, I only took, Tylenol for fever, and otherwise kind of left it at that. But the detail in some of these regimens was really impressive.
Excellent. There's another question, Sapna, that says, I'm a developmental pediatrician and I'm wondering how aggressive we should be with children being admitted for COVID and their neurodevelopmental follow-up.
I think you can't be aggressive enough. In fact, at Kennedy Krieger Institute, I just got an email today that they've organized a neurodevelopmental follow-up clinic for COVID-19 patients that involves the physiatrists as well as the neurologists and the rehab team. I think that, again, we don't know enough about how this will impact neurodevelopmental outcomes, but seeing the neurologic manifestations in adults, I can only imagine that it will have some impact on kids. And I think, I don't know at what point, what day do you refer them, if it's mild, moderate, severe, but I think it's something that we really need to think deeply about. And when in doubt, just refer them and get them the follow-up. Thank you for that question.
Excellent. Another question for any of the panelists, really, do you find that the patients with more predominantly refractory hypoxemia suffer more from delirium and the encephalopathy?
I think that, I think that a lot of the people who are very hypoxic, who are intubated for a really long period of time, have significant delirium, and in part because they've just been sedated for so long, required a good bit of sedation. I mean, at least we're finding that people require more sedation than you'll see in typical ARDS or typical ICU patients, and that may be in part secondary to fevers and and deep sedation for neuromuscular blockade, but a lot of people seem to have a significant amount of delirium after.
I just wanted to add, I agree with Sandy that those patients are definitely the highest risk for all of the usual reasons. But also I've seen patients who are in the unit for a day, like I said, on high flow and having severe hyperactive delirium, trying to run out of the room, et cetera. And these are patients who are cognitively completely normal at baseline. So it does happen, and that's the most concerning part to me. It's not the usual suspects always.
Excellent. I think there's a question here for Dr. Levine. Did you come across the discussion of the different lung COVID phenotypes that Dr. Gatnoni mentioned in any of the clinical trial designs?
No, so I don't think these phenotypes are mentioned in any of the trial designs. I don't think any of the drugs are targeted to those phenotypes, and I don't think the progression or the outcomes related to those phenotypes are looked at in any of the clinical trials I looked at.
Sapna, you have thoughts about the phenotypes discussion? The idea of
no, nothing to add to that. No.
Yeah, this has been a topic that we've seen in the kind of Twitter world, as well as YouTube videos and a lot of different areas. I think from our perspective, I'll tell you from the University of Maryland, we're sticking to what we know. We take care of these patients with the tried and true therapies that we know work, low tidal volume ventilation when they do get intubated. We're not intubating people that are not in respiratory failure. We are intubating people that are in respiratory failure. And just because someone has hypoxia doesn't mean that they're in respiratory failure, right? So I think that this idea of waiting till the very last minute to intubate patients is kind of a false, in my opinion, is a false conversation, because we don't intubate patients for sole hypoxia. We intubate them for respiratory failure. And so that I had to put my 2 cents in there for that one as well. So there were some questions in there about kind of the thromboembolic disease and anticoagulation and kind of different protocols that are out there. Does anyone have any thoughts about that?
And personally, I think my approach has been to treat these patients, like you said, much like other patients with ARDS. When I have a patient who has ARDS or they have hypoxic respiratory failure that I can't explain, I always put PE in the differential or some sort of thromboembolic event. And these patients who are too sick, too unstable to send down to the CT scanner, or they have renal failure, they're on profound amounts of oxygen, or they're difficult to sedate, I keep it on my differential. And then if their D-dimer supports a hypercoagulable state, or if their chest x-ray to me doesn't explain their degree of hypoxemia, then I start to really think that maybe they have a PE and I just can't safely make that diagnosis. So if they don't have a contraindication to anticoagulation, I'm proceeding with anticoagulation in these patients. And I'm not sure yet what that will mean for their outpatient follow-up and their long-term care. Will I send them out on DOACs or whatnot? But that's kind of been my approach to it. I know there's a couple scores that our pharmacists are using to kind of help determine who should be on anticoagulation and at what dose, but that's my clinical approach.
It's a little bit tricky. So I think in the first 24 patients that were in our Hopkins ICU, I think 6 of them had a clot. So 25%, pretty good number. And those people were initially were using a very standardized like hospital ICU DVT prevention protocol. And we've actually escalated to sort of like a high dose DVT prophylaxis in a number of our COVID patients, just because of the concern for development of clot. I think what makes the D-dimers really tricky in these patients is that they're markedly inflamed. And so the D-dimers are often very elevated. So I think you have to be, at least I've just found like you have to be concerned for clot, especially when D-dimers are really high, but it's not always the complete answer to what's going on.
And our high dose prophylaxis is generally the trauma prophylaxis that the surgeons use. And then like Sandy was saying, there's like this it's a complex protocol, but not too complex. And it's relatively aggressive because of what we've been seeing in our patients across the board.
And I think there's been recent manuscripts that actually back up exactly that number that you're seeing. There was a radiology research letter, I think from a couple of weeks ago, that found a 23% rate of PE in these patients. So, very high and should remain high suspicion.
There's a lot of conversation and chatter in the box around this whole idea of intubating and when do you do it, and at what point do you intubate the happy hypoxemic patient. I think we briefly answered that. I don't know if anyone has anything to add for that conversation on this about when you would intubate somebody who's our happy hypoxic patient.
Yeah, I mean, Nirav, I think I go exactly with what you said earlier. Early on the talk was, oh, we have to intubate these patients as soon as they hit like this level of oxygen saturation. But again, it's like back to basics. Like, in what scenario would you intubate any other patient with respiratory distress, and what are the parameters? And so I think it's evolved significantly over the last several weeks since this really started. And I think everyone's being much less aggressive in terms of intubation until the work of breathing, all of the other parameters really meet criteria. That's typically been our practice. I'll let the others say what they think.
Yeah, I would agree. I mean, I think 3 of us are from Maryland here, and so I think we have the same practice. And Sandy probably the same at Hopkins as well.
I just wanted to say that like one of the other patients I saw in this packed clinic today was an 80-year-old woman with COPD who actually was requiring significant amounts of high flow nasal cannula, and we actually staved off intubation by proning her non-intubated. And she was able to tolerate, not everyone can tolerate it because they get back and neck pain, but she was able to tolerate it quite well. And so that was a pretty awesome case. So, some alternative ways of thinking about it.
Yeah, Sandy, that leads into maybe kind of the concluding questions here that we can ask. And that's, I think people are impressed by the fact that you have a clinic that you're following these patients in, and in particular, did this patient that you took care of that came to clinic today, was the dysphagia resolved? Did the patient leave with an NG tube? And then also, is this a clinic that's dedicated solely for COVID patients?
Yeah, so the dysphagia completely resolved. It actually resolved by the time that he left the hospital. So he was like, I'm trying to gain my weight back and I'm eating all of my nutritious foods. I said, okay, that's good. So lucky for him, he did really well with that. And this was a clinic developed by Ann Parker and who works with Dale Needham. and Sarath Raju. And so they're the faculty leads on it. And then all of the fellows get to rotate through if you choose to. And it's exclusively for COVID patients, and it partners with PM&R, so physical medicine and rehabilitation, and then tries to plug people into physical therapy, occupational therapy, speech therapy, if they have sort of missed that resource going out of the hospital. Also tries to set them up with remote monitoring if they're requiring oxygen to see what their saturations are doing, because obviously it's very tricky seeing people and caring for people in this current era. So this was my first day in clinic, and it was awesome. I really enjoyed seeing the people I'd cared for in the hospital, and I know some of my co-fellows have felt similarly.
Great, thank you. I want to thank all of our speakers today. Steve Cassady with this quick case of our pregnant patient with COVID, and then Dr. Levine with what's a buzz around the clinical trials. Dr. Cassady Zaeh with a case of a patient she took care of and then got to see in clinic today. And then Dr. Kudchadkar with my journey with COVID-19 as a patient and an intensivist. I want to thank all of you for tuning in. This is our American Thoracic Society COVID-19 Critical Care Training Forum, Tuesdays at 8 p.m. Eastern Standard Time, 5 p.m. Pacific Standard Time. I also want to thank our working group, Ren Call, Laura Crotty-Alexander, myself, Isabel Pedraza, Andrew Edmond, Christine Bojanowski, Lakshmi Santosh, Sushma Cribbs, Matt Drake, and Michelle Soffler. We have an internal resident team out of UCSD, and then our ATS staff, Lauren Lynch, Liz Guzman, Eileen Larson, all of which this couldn't be possible without all of their hard work and dedication to making this happen every week. And with that, I'm going to bring the meeting to a close. I appreciate all of your questions, and really thank you all for joining today and making it so interactive. Thank you to all of our presenters today. It was a pleasure to have you on.
Thank you.
Thank you.
Thank you.
Thanks, Nirav.
Bye.